Okay, guys, Timmy coming at you, and what I want to do today is just go over that worksheet that I gave you. I'm making a tape of it, video of it, because there's a few more things I want to explain, and to be really honest, they're very important clinically. So let's get to it, and then I'll explain to you why understanding this is really important. All right, number one, look, the brain and spinal cord make up the central nervous system. This is really important. The central nervous system is the primary processing center. The brain, obviously, is the king of processing neural information and then making decisions and then doing stuff about it. But the spinal cord also processes neural information. Let me explain real quick. One of the things that the spinal cord processes is reflexes. And let me explain to you why this is important. Now, look, let's say, for example, that somebody put their hand on a tack. Just so you know, don't do that, all right? Now, look, the spinal cord is made up of those 31 pairs of spinal nerves. But within those spinal nerves, there's a sensory nerve, which is always on the dorsal part of the spinal cord, the dorsal root. And then you have the ventral root, which is motor. And in between the sensory nerve and the motor nerve is what's called an interneuron. And basically what the interneuron does is, well, it does a couple of things. Number one, because you have this neuron here, it only permits neural transmission this way. If there wasn't the interneuron, what you would do is spend your entire life taking your hand off and putting it back on the tack, right? So you would get this reflex going back and forth, and you know that's not good for, well, anything. Now, let me explain to you why that's important, why we have that. If all you had was you put your hand on a tack and then you felt that, and then you had to make a decision about whether or not you were going to pull your hand away, that takes time. And as a result, that can lead to a lot more damage. Think about putting your hand on a hot stove. If you had to think about, hey, you know what, maybe I should take that off, it's going to lead to more tissue damage. So really the function of reflexes, and those are again directed by the spinal cord, their purpose is to make sure that you're safe. Reflexes are designed to spare your life, all right? So that's important. And there's a couple more things I want to go over, but let me knock this out. All right, and we talked about that. Number two, there's 31 pairs of spinal nerves that make up the peripheral nervous system. And then the peripheral nervous system is further subdivided into the autonomic and somatic. And I've gone over this ad nauseum, I mean, for real. The autonomic, somatic. Somatic is under conscious control, so that's skeletal muscle, right? And we know the neurotransmitter for skeletal muscle contraction is always acetylcholine, always. And then the autonomic is further subdivided into the sympathetic and parasympathetic. We know this, right? And the sympathetic is referred to as the fight or flight, and the parasympathetic rest and digest, right? These other ones, I really shouldn't have to go over. I mean, you should, cut it out, right? But one of the things I want to explain to you, and they love this in clinical, and they love it on the NCLEX, is this condition called autonomic dysreflexia. I'm not going to go into a lot of detail about it, but what I want to do is I want to explain to you why it happens. And again, if you understand a little bit of anatomy and a little bit of the physiology behind it, it makes perfect sense. Now, if you look, and I explained this to you before, the sympathetic nervous system, come on, Timmy, the sympathetic nervous system, oh boy, here we go. One more time. The sympathetic nervous system kind of comes off the middle of the spinal cord. And then as you can see, as the spinal nerves exit the spinal cord, they get grouped in series. So I explained this before. That means that you can't activate just one part of the sympathetic nervous system. If you're going to turn on the sympathetic nervous system, for the most part, you're going to activate all of it. Now, if a person develops a spinal cord injury, and it's typically above T6, so if they develop a spinal cord injury typically above T6, and this little red line represents the area where thoracic vertebrae number 6 would be, the brain can no longer communicate with anything that is distal, right, or lower, caudal, to that injury, right? So the brain can't communicate with it. Now, the vagus nerve we know is one of the cranial nerves, so that still functions. And if you look here, you can see that some of the sympathetic ganglia, some of the groups of the sympathetic nervous system will still function. And again, their job is to protect you, fight or flight. Now, watch. When a person has a spinal cord injury, they lose both sensory and motor. So they can't feel anything and they can't move anything below the site of the injury. However, if something is happening to this person, and the examples they give here are good ones, and they're very realistic too. I mean, this is for real. Skin breakdown, fecal impaction, don't want that. A full bladder. Now look, these people can't pee on their own. So if they're a quadriplegic, then they need a Foley catheter. So if that catheter becomes clogged, then their bladder will begin to distend. Now this is the important piece. Below the site of the injury, you're going to get activation of the sympathetic nervous system. So what is that going to do? We know what it does to the blood vessels, the arteries, right? It causes massive arterial vasoconstriction. Where? Well, everywhere below the site of the injury. Why? You're having some type of pain. There's some kind of distress going on below the site of the injury. Now, what's happening? What's going to happen to your blood pressure? Well, your blood pressure is going to go up, right? And we know that the medulla, no worries for the rest of your days, right? The medulla is going to sense that increase in blood pressure in the blood vessels. And what it's going to do is it's going to stimulate the vagus nerve. And we learned that the vagus nerve is part of the sympathetic. And the sympathetic, right, increases your heart rate. Parasympathetic vagus nerve is going to cause a decrease in heart rate. And because of that rapid increase in blood pressure, and the brain saying, hey, what the hell is going on? Everything up above the site of the injury, I'm cool, right? I'm okay. But below it, and remember, any damage below it cannot be communicated to the brain. So the brain's like, what the hell is going on? All the brain knows is that your blood pressure went really, really high. So I got to try to lower it. So one of the ways I can lower it is by lowering my heart rate. That's done by the vagus nerve. Then the vagus nerve, along with the medulla, is going to cause massive arterial vasodilation. Now watch. The vagus nerve and the medulla can't communicate below the site of the injury. So above the site of the injury, they're going to become flushed, right? Their nose is going to get stuffy because all the blood vessels are dilating. They're going to be complaining of a freaking headache because of the increase in pressure, and they can stroke out. They're like 4 times greater risk of developing stroke from this. So this is no joke. So they're going to be sweaty, right? They're going to be flushed, and they're going to be complaining of a headache. Their nose is going to be stuffy. But below the site of the injury, what does the sympathetic nervous system do? It causes massive arterial vasoconstriction everywhere below the site of the injury. So that skin's going to be pale. It's going to be cold, right? And the reason for that is the sympathetic nervous system was activated below the site of the injury, and then the parasympathetic, right, and the medulla are responding to that increase in blood pressure by causing your heart rate to drop and the blood vessels to dilate. Now, the key to dealing with this is finding out what the heck is going on, what's causing the activation of the sympathetic nervous system. And a lot of it can be infection, like a UTI can cause this. So this is no joke. And I've dealt with people who were paraplegics, and it's almost universal. Before I leave, they were always asked, Tim, can you check my Foley? Make sure there's no kinks or anything, because they've experienced it. So I didn't want to go into too much detail about that, but that's really important to understand. And I guarantee you that that will come back and haunt you. And maybe you'll just remember that we did a little piece on this, and it will help you. You know, that's my goal. Anyway, let's just get back to this. All right. Sympathetic increases your heart rate and blood pressure, right? And remember that the neurotransmitter for sympathetic stimulation, right, is norepi, and parasympathetic is acetylcholine, right? And norepinephrine is adrenergic, and acetylcholine is cholinergic. So you're going into clinical, they're going to ask you to know this. And remember, real important, you always have some sympathetic stimulation, you always have some parasympathetic stimulation, right? When you're resting and digesting, you got more parasympathetic. When you are running and fighting for your life, you have more sympathetic. But you always have that background, parasympathetic or sympathetic. Parasympathetic nervous system is going to cause your pupils to constrict. Sympathetic is going to cause your bronchioles to dilate. Now let's talk about the protective layers of the brain, right? Let's look. And I went over this in the video. There we go. All right. Remember that the central nervous system doesn't have a lymphatic system. So you got the pia mater covering the brain directly. Then you got these like little protein girders that resemble a spider's web, and it suspends the next layer called the arachnoid layer above the pia. And then this area here, colored in yellow, that's the subarachnoid space. That's where cerebrospinal fluid circulates. Then you have the dural layer that covers the inside of the skull and the brain and spinal cord. But the dural layer in the brain, the top of the brain and around the brain by the cerebellum, the dural layer actually folds on itself and forms that little pocket called the dural sinus. And the dural sinus is filled with venous blood. All right. So, and also too, you know, with those astrocytes, and it's really, really tough to get medication and stuff into the central nervous system. That's why central nervous system disorders are very difficult to treat. And a lot of those drugs have really, really serious side effects. Like Parkinson's, for example, those drugs have really, really nasty side effects because you have to kind of trick the blood-brain barrier into allowing those drugs in. All right. So the inner protective lining, pia, that means delicate mother. And then suspended above the pia is the arachnoid layer. And then the pia mater, above it and below the arachnoid mater is the subarachnoid space. And that's where cerebrospinal fluid circulates. And I just went over this. The dural sinus, again, is filled with venous blood. And then the true spinal cord ends at L1. Now, there are some nerves, and then you have what's called the cauda equina, or horse's tail. And that embeds into the coccyx of people's. And that prevents the spinal cord from flopping around inside your spinal column. You don't want that. It doesn't look good. So, right here at L1, and then you have the cauda equina that lodges into the coccyx. So again, that spinal column's not flopping around. All right, and then the choroid plexus and the ventricles are responsible for making cerebrospinal fluid. And I went into that a little bit. If you look at that handout on the specialized cells, supporting cells of the central nervous system, I talked to you about ependymal cells and the choroid plexus. Now, some of the functions of cerebrospinal fluid are to cushion and protect the brain and spinal cord, obviously. Also provide buoyancy for the brain and spinal cord to reduce its weight, right? So, you know, the things in water are lighter than things in air, right? And then it also kind of works like a circulatory system, especially for the cerebrum, right? The lobes of the brain, they provide nutrients, remove metabolic waste from the central nervous system. And then cerebrospinal fluid is basically blood plasma, right? You shouldn't have white blood cells, red blood cells in cerebrospinal fluid. That's always abnormal. And then on average, the choroid plexus manufactures about 450 to 500 cc's of CSF per day, but only 150 circulate around the brain and spinal cord. And that's because, and we learned this, you better watch that video. That's because there are little drains that connect the dural sinus to the subarachnoid space. Those are called arachnoid villi or arachnoid granulations. And they basically then drain the excess cerebrospinal fluid into the dural sinus, and then the dural sinus returns it to the general venous circulation, then to the right side of the heart. Now, some people, when they're born, they can have malformations of that while they're developing in the womb, and they will continue to produce cerebrospinal fluid, but it won't be able to be adequately drained. And as a result, we remember from general that the fontanelles, the bones of the baby's skull, are not fixed, right? Because the brain grows a lot during the first couple of years. So what will happen is that fluid will begin, the cerebrospinal fluid will begin to expand the kid's head, and the brain's relatively soft tissue, so it'll begin to crush the brain a little bit. So a lot of these kids come out with hydrocephalus, and they also end up usually being mentally disabled too, because of the increased pressure and then cutting off the blood flow to the brain. All right, and then I just talked about this. Excess cerebrospinal fluid from the subarachnoid space is drained from the subarachnoid space by the arachnoid villi. And a correctly performed epidural results in a spinal needle entering the subarachnoid space. Couldn't be farther from the truth, right? Epi means above, right? So dura is the outer layer. So an epidural should be done outside or above the dura. So it should never enter the subarachnoid space. That's poorly done. So here, if you look, here's the dural layer. And then in the spinal cord, or spinal column, you have a dural space right here.